Ladies and gentlemen, a very, very warm welcome to the ECTRIMS 2025 Congress. It's a so great pleasure to return to this vibrant city of Barcelona with this joint congress with RIMS this year.
I'm really convinced that together a more attentive clinical care, technological innovation, and science-driven treatment approach can make preservation of cognitive function in our patients a realistic goal.
So using EC transcriptomic isolated from normal brain tissue, can we identify heterogeneity between regions? And the answer is yes, we can.
A deeper understanding of MS biology, combined with new technologies, is reshaping the way we care for patients with MS.
It is quite likely that chronic low-grade inflammation over a long time and different types of exposures are contributing to senescence impairment and inflammation. But we really have to be careful because there are so many factors that are impacting these clocks.
We see AI could theoretically help us, but there are problems. There are risks, and one of the risks that I would like to stress today, because there are many, is explainability.
Broadcasting directly from Barcelona, Spain, you're listening to the ECTRIMS podcast, the official podcast channel of the European Committee for Treatment and Research in Multiple Sclerosis. I'm your host, Brett Drummond, and welcome to this special Congress series. Day 2 of ECTRIMS 2025 has just finished, and Barcelona is well and truly alive with the energy of more than 9,500 delegates immersed in science, collaboration, and discovery. This meeting is more than just a congress, it's a global forum where the brightest minds in MS research and care come together to set the agenda for the future. Today, the program reaches one of its high points, the prestigious ECTRIMS Lecture, alongside a series of hot topic sessions that bring bold new ideas to the forefront. From mechanistic insights to novel biomarkers to artificial intelligence, novel digital technologies, and therapeutic strategies, the conversations happening today have the power to reshape the landscape of MS research. It's science at its most ambitious, shared on a global stage. On today's episode, I'm joined by Maria Pia Amato, a professor of neurology at the University of Florence, who delivered this year's ECTRIMS Lecture, sharing her pioneering work in cognition that continues to enrich how we understand and address cognitive challenges in MS. Today, we bring you the key highlights of Day 1 at ECTRIMS 2025. Maria Pia, thank you so much for joining us today.
Thank you for having me.
So you gave an absolutely amazing lecture this morning, focusing all on cognition in multiple sclerosis, a topic that you've been passionate about for a really long time. Can you tell us how cognition research has changed over the years and where you think we're at now with cognition in MS and our understanding of it?
When we think of multiple sclerosis, the first things that come to mind are usually physical symptoms, walking difficulties, motor disability. But if you ask people living with MS, often other issues come up, cognitive problems, things like problems of memory, attention, processing speed, the ability to stay focused, sometimes difficulties with word finding or dual tasking, that is, performing a motor and a cognitive task at the same time. These are the abilities that allow us to work, to study, to enjoy social life. And when they are affected, the impact can be huge. In fact, an international survey that I presented this morning tells us that more than 70% of people with MS experience cognitive symptoms, problems with memory and concentration. And these problems are often the reason why people leave their jobs, even when they still have little physical disability. We learned in recent years that these changes can be early changes. Sometimes they can appear even before the first classical neurological symptoms. We see them in children and adolescents where they interfere with school and social engagement. And at the other end of the spectrum, as people with MS live longer, aging itself adds an extra burden. So cognition is not just a late complication of multiple sclerosis. It's something we have to consider throughout the whole course of the disease.
So I think you shared quite a personal story in terms of why you started to get really interested in cognition with MS with a nurse that you worked with. Can you tell us that story and how it inspired you to really get involved in this field?
Sure. In fact, one of my first patients was a nurse with multiple sclerosis. I was a resident at that time, and she had only minor physical disability. She could walk independently, but she was struggling more and more with the memory and concentration issues. She eventually decided to change her role at work because she no longer felt safe administering medications to patients. This story really struck me. It showed how cognitive difficulties, even when invisible, can deeply affect a person's professional life, self-confidence, and identity. It also reminded me how important it is for us as clinicians to listen carefully, acknowledge these concerns, and work together to find solutions.
I think that is a really powerful story in terms of why this is something that needs to be taken really seriously, monitored really continuously throughout the life of a person living with MS. Cognition research has come a long way. And I think one of the really interesting pieces of data that you presented today was work that you're involved in, where you've identified a number of different cognitive phenotypes that seem to be present in people living with MS. Can you talk to us about that research?
Yes, thank you. In fact, it's an interesting new field of research. And what inspired me is that dichotomous classification into those who are preserved, those who are impaired. Clearly, this is an oversimplification. And it produces groups of patients that are different in terms of number of tests failed, type of functions involved, severity of the involvement. So we used this big data with a data-driven statistical approach and identified these 5 major phenotypes that represent a continuum from preserved cognition to mild impairment in a few cognitive functions to severe impairment. And what is particularly interesting in my view is that each of these phenotypes has different MRI patterns underlying the cognitive problems, from thalamic atrophy to hippocampal atrophy when you have a phenotype characterized by memory problems, to cortical atrophy, to widespread changes in the white matter and gray matter when you have a severe multi-domain phenotype. Mm-hmm. And there are other groups that are working to refine these phenotypes, but results, I think, are encouraging because they result to be quite similar. Mm-hmm. So, and there is now an ongoing project led by the Magnims group. It's an international cohort study where we are participating. And I think this will be useful for research, first for overcoming this dichotomy, then also to have a better understanding of different physiopathological underpinnings underlying different phenotypes, and also can be useful for treatment because this approach can be soon adopted in clinical trials, being these of rehabilitation or pharmacological interventions to recruit homogeneous groups of patients and provide more targeted treatment and possibly more effective interventions.
Yeah, definitely. I think your link to clinical trials was really interesting in terms of the improvements that can be made now that we understand these different cognitive phenotypes.
Yeah.
You also talked about how you really want to see cognitive outcomes included more in clinical trials. Can you talk to us a little bit about that?
Yes, this is a long story. Usually in clinical trials, the cognitive outcomes are secondary or tertiary or exploratory outcomes at best. We don't have any information about the cognitive status of the patients at entry, no size calculation based on cognition. So I do think that really we should start to prioritize the cognitive outcomes in future trials because they can say something about this silent progression or hidden symptoms that cannot translate into a change in the number of relapses or in the disability progression calculated through the EDSS. But I think that also observational studies are very important because they can provide long-term follow-up, robust follow-up. And I think the story of the pediatric MS is telling us very much. Because, you know, in earliest studies, the pediatric population had really important cognitive disability, much more than physical disability. And now we see that the percentage of pediatric patients with cognitive problems in the latest study is decreasing, and also probably the progression rate of these cognitive difficulties is decreasing. And this is due to observational studies with long-term follow-up, adequate follow-up.
Yeah. And so it's really important that I guess in these large databases we're including cognitive outcomes in terms of the data that's being collected so that these studies can be performed.
Yeah, absolutely. And I think that the story of the pediatric MS is telling us quite a lot also because, in the last few years, we have seen important improvements in terms of earlier diagnosis, earlier treatment with high effective drugs. And this tells us that this can have an impact also on the cognitive outcome, probably more than a 2-year trial where you don't know the starting point.
Yeah. I have pages of notes that I took from your lecture this morning, but I want to finish talking about your lecture with the quote that you said right at the end, and I didn't get it down perfectly, but the message was really that you're convinced that preserving cognitive function in people living with MS is a realistic goal. Can you describe why you're so confident about that?
I am confident because, first of all, it's important to test cognitive faculties from the very beginning and then regularly test over time so that you can provide some adaptive or coping strategies or even cognitive rehabilitation. But you should try to prevent cognitive disability. So it's important also to, of course, early and effective treatments to preserve brain volumes and brain tissue, but also the lifestyle is important to have they call them a brain healthy lifestyle, healthy diet, addressing modifiable risk factors such as smoking or alcohol consumption that are, of course, can worsen your cognitive function, and also to have a mentally and physically active lifestyle that can increase what we call your cognitive reserve, a sort of buffer against brain damage that can protect you to some extent from cognitive impairment or from aging. For instance, there are lot of studies in degenerative dementia that people with higher cognitive reserve really can deal better with aging and brain aging.
I'd love to continue talking about your presentation. It was fascinating. I'm sure it was a lot of people's highlight of today, your lecture. But for you, other presentations that you heard today, what other highlights did you have from sessions that you were able to attend in a really busy day one of the conference?
Yes, I attended the European Charcot Symposium at ECTRIMS, and we discussed about a question that is very timely and fascinating, whether MS has a prodromal phase. In medicine, a prodrome means early and often subtle signs or symptoms that appear before a disease is fully diagnosed, recognized, and diagnosed. In Parkinson's disease, for example, researchers have long studied early features like depression, sleep problems that may appear years before the classical motor symptoms. What about MS? In recent years, there are emerging epidemiological studies that show that people who later received an MS diagnosis had higher use of healthcare services in the 5-10 years prior to the first clinical manifestation, more medical visits, more hospital admissions, more prescriptions. And it seems that psychiatric issues and mental issues can be among the earliest features of this prodromal phase. Of course, these are non-specific symptoms. They can overlap with the prodromal symptoms in other conditions, so we need to identify biomarkers to better characterize this prodromal phase. And there are emerging studies, there is emerging evidence about, for instance, an immunological dysregulation several years before the appearance of the clinical onset of the disease, autoantibodies that are very specific to MS. Of course, they are not sensitive because they are found only in a minority of the subjects. So we need to continue to search for these biomarkers and combine these with clinical information, signs and symptoms to derive a risk score, let's say, for that specific subject to develop MS. So it's an exciting perspective, not only to treat MS, to treat early, but even in the future maybe prevent MS.
And a prodromal phase, interesting link with cognition, because I believe some of the research has shown people who go on to be diagnosed with primary progressive MS might have cognitive impairment decades before their MS diagnosis, which is fascinating.
Sure. In fact, this is a study based on the Proscription Service database in Norway. These young men, those who later developed multiple sclerosis, exhibited reduced IQ scores compared to matched controls years before the development of the first classical neurological symptoms. And in case of primary progressive disease, even 20 years before the first neurological symptoms. So really cognitive problems can be some of the earliest features of the disease. There are also important studies, several studies, very consistent, showing that people with radiologically isolated syndrome, so MRI lesions highly suggestive of multiple sclerosis, but without any signs or symptoms, they can have decreased cognitive performance, subtle cognitive deficits that can correlate with decreased brain volumes, actually.
Well, day 1 is finished. We still have days 2 and 3 to go, busy days to go. What are you most looking forward to over the next couple of days?
One is, to me, aging with multiple sclerosis. In fact, due to the increased life expectancy, our population is aging, which raises a number of challenges regarding treatment decisions. In older patients, we have to think not only about efficacy, but also about comorbidities. There is higher risk of infections, even malignancies or secondary autoimmunity, decreased response to vaccination, all related to a phenomenon called immunosenescence, reduced efficiency of the immune system, and inflammaging, low-grade chronic inflammatory state. And it's intriguing to me because clinical trials usually exclude elderly people, so there is very limited information on this topic, and the answers can be provided by high-quality real-world studies with adequate follow-up regarding both the efficacy of the drugs and the safety in the long term. Another topic I'm particularly looking forward, of course, are the sessions on new and emerging treatments for multiple sclerosis, new monoclonal antibodies, BTK inhibitors, CAR-T. I am really looking forward to hear about these emerging therapies.
Well, I want to thank you for your amazing lecture this morning, all of the incredible work that you've done to really take our understanding of cognition in MS forward, and for sharing your insights with us today after an incredibly busy day for you. It's much appreciated.
Thank you. It was a pleasure to me.
Thanks everyone for listening. Be sure to join us again tomorrow as we continue our special ECTRIMS 2025 series, where I'll be joined by Barry Singer, who will be highlighting all the standout insights of Day 2 of ECTRIMS 2025. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MS Translate. The ECTRIMS podcast is produced and hosted in collaboration with 2 key partners: MS Translate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community, and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2025-26 ECTRIMS podcast series is supported by educational grants from Alexian AstraZeneca Rare Disease, Bristol Myers Squibb, Novartis, Roche, Sanofi, and UCB. Educational grant providers have no input in the podcast content. Subscribe to the ECTRIMS podcast on all your favourite podcast channels, including Apple and Spotify. Visit the official ECTRIMS 2025 website to learn more about the ECTRIMS Congress, and join the conversations on X, LinkedIn, Facebook, and YouTube.